Well, good afternoon, everybody. It's really my pleasure to speak at Prism Week. Thank you so much, the organizers, for putting in all this work and for making this happen and for inviting me to talk. I'm going to talk today about the work that goes in my lab, and I like to take credit for it, but really the credit goes to all of my students and trainees, some of whom are here. So thank you so much for all your work on this. We're working on a really important problem, which is ovarian cancer. So the challenge is that current methods for screening and early detection, which can include the blood test, CA-125, a manual exam, and ultrasound, have really had limited success. They're not appropriate for detecting early cancer in the general public. And non-invasive imaging modalities, whole body techniques like CT, MRI, and PET, have limited resolution and sensitivity and really high cost. So they're also not appropriate. Optical methods, on the other hand, have high resolution, high sensitivity. They're very appropriate, but we're not transparent. You can't see through us with light, which means you have to get direct access to tissue. So what's the opportunity? Major advances in technology that have occurred recently: genetic testing, proteomics, optics, new materials, new flexible, strong materials, tiny fibers, sensors, and light sources. There's also been a biological discovery that ovarian cancer can exist as a precancerous lesion in the fallopian tubes for years. Some models say that it might exist for up to 6 years in the fallopian tube before those cells break off and go to the ovaries. And this is an example of how that, an illustration of what that does. The idea is that it's actually, can you all see my cursor? It's the fimbriae, the end part of the fallopian tube, that actually goes dysplastic. And for whatever reason, cells in that environment are abnormal, but they don't grow. But eventually they break off and seed themselves on the ovary. And for whatever reason, then there, in that environment, they rapidly proliferate, distribute out through the abdomen. And so that's why you don't see early ovarian cancer. By the time it's gotten to the ovary, it's actually already metastatic. So what we're looking for in the fallopian tubes is really a change from, this is a histological section of fallopian tube, more normal, that has this nice single layer of epithelial cells on the top. Those cells become dysplastic, the nuclei gets really large, and then the epithelium thickens. This is what we want to see, thickened epithelium in the fallopian tube. All right, so if we lay out all the tools that we have available on this plot that shows resolution on the y-axis and depth of penetration on the x-axis. So we know that things like MRI and CT are way out here. They can see through the whole body, but only with a millimeter of resolution. Whereas microscopy can only work on thin sections, but it has exquisite resolution. So maybe we want to work somewhere in the middle of this, where we can image maybe up to a millimeter deep, because that's about how thick an epithelium is. And if an epithelium is thicker than 1 millimeter, it's definitely abnormal. Yet we still get good enough resolution. So we're going to focus on a couple of things, but I don't know if any of you all have seen this in any of the labs. So maybe more so in my day than in yours. You know, if you wanted to build a femtosecond laser system, you had to have something just that occupied the entire table, and it was a mess. And it took a postdoc a year to align, and then they'd get the one result and then say, okay, I'm done. That's no longer true. You know, now we can do things and package them. This is Nestor Pegambarium's, one of his lasers that's packaged all neatly in small fiber systems. This is what I mean about technology. Whereas we can't take an optical table into the operating room, we can certainly take one of these small lasers. Same thing has happened with this old ugly bench systems that everybody used to use for lenses, with big gigantic lenses that you had to align. Whereas nowadays, more and more, they're tiny optics. They're now millimeter diameter optics that are off the shelf. Not a huge variety of them, but you can just go to Edmund Optics and order them nowadays. Interferometers used to be something that was on a table. Now they're fiber optics. Basically, what this means is that when we used to bring the sample to the microscope, we can now bring the microscope to the sample or the body. We have endoscopes. We can stick these tiny optics inside a small endoscope and put them in the body. So I'm going to focus on a couple of imaging modalities for this talk. We've used a few in my lab, but one of the ones that we really like is called optical coherence tomography. The purpose of OCT is to image tissue microstructure. So it's really ultrasound with light. Because light has much higher frequency than ultrasound, you get much better resolution, 2 to 20 microns. So maybe not quite cellular resolution, but definitely microstructural resolution. You can image 1 to 2 millimeters in imaging depth, and it measures reflected light. So we have light do basically the same thing that ultrasound does. You put in light, and you time how long it takes to come back from reflections. And by that timing and the amplitude of the reflections, you can build up a cross-sectional image. Now, light travels a lot faster, so you have to deal with the fact that you can't just do pulse echo like you can in ultrasound or echo when you're like shouting across a canyon, but it's the same idea. And light also doesn't penetrate as deep in the body. But you can do things like here. Now, this is where maybe you can't see it up on the screen so well. This is actually a precancer in the skin. This is what happens to anybody who lives in Tucson for too long and doesn't use sunscreen. You get these things called hyperkeratosis. You can take it inside of blood vessels, and you can look for stent struts, and you can look for healing over those stents. This is actually a mouse colon. So this whole picture here is only 3 millimeters by 0.5 millimeter deep. And yet we can see the individual crypts. We can see the boundary layers. We can see all the different structures. So it's simple, it's robust. It's something that we can definitely put inside the fallopian tubes. Another one that I like to work with is called laser-induced fluorescence. We all glow. I'm sure you've seen yourself under a black light. Turns out that you glow differently in health and disease because some of the things that are naturally in your body, such as collagen, NADH, and FAD, vary in disease and they're fluorescent molecules. We also, of course, can apply exogenous compounds, either targeted or untargeted, that can pick out certain areas and highlight them. So the idea of laser-induced fluorescence is very simple. We all fluoresce. If you dump light on the tissue, all these different molecules in your body will absorb that light and re-emit it at longer wavelengths. And when those re-emit, we can collect that light back and take it to a spectrometer, and we can analyze the different wavelengths. Oh, that's annoying. So as I said, amino acids, collagen, metabolic factors, blood, contrast agents, we can look at all those things. I think that's maybe inside of here. I think it's in the closet. Sorry, there's an annoying warble. Let's hope it goes away. All right, so the next problem we have is that advanced imaging systems tend to be bulky, not robust. So this isn't my current lab, but Jenna, you probably recognize this. This is what it looked like when it was over in Keating, the multiphoton microscope. Okay, this is an OCT system. They're huge. They're spread out all over the place. And again, you're not wheeling this over to the operating room. So we need to take all of that and we need to turn it into something that looks like what the physicians are used to. This is really key. Physicians are trained for years, spend years and years and years training. They want something that looks like what they've been trained with. So this is a conventional white light endoscope. This exists right now. It allows you to take a camera, put it down, in the colon or in the esophagus, and take a look just with white light, just at the surface. Can we improve on this standard? So a couple things we're going to have to do then. How do we access the ovaries and the fallopian tubes? It's not as easy to get to as the esophagus, where you can just go down your throat. All right, so there's a couple of different ways to get to the ovaries and the fallopian tubes. The first way is laparoscopically, and that's actually where you put an incision in the belly. And you can stick cameras and different instruments in there, and you can do surgery that way. Try to get rid of, I don't know why I can't get rid of that. The second way is transvaginally, and that's where you can go through the vaginal wall and you actually get into access into the peritoneal cavity that way, and you can access the ovaries. This is what's used nowadays for egg harvesting and in vitro fertilization. So usually in this case, it's an ultrasound guided needle that's going into the ovaries. Or there's a falloposcopic way in which you go up through the uterus and into the fallopian tubes. Now, we don't want to do this way, because if you do laparoscopically, actually we have done this, But this isn't any good for screening. Can anybody guess why this is not an appropriate screening procedure? Right, it's a surgery. You have to go under anesthesia. It's a very low risk, but it's not zero risk. And it's uncomfortable, and there is some recovery time. So while this was great, we had a proof of concept instrument that we turned into a rigid laparoscope, and we did OCT on the ovaries that way, kind of proved that we could do it, that we could get stuff into a cart, get it. You have to go through electrical safety, you have to go through infection control and prove that you're sterile, all those types of things, but not good for screening. But we were able to take images. So these were some of our first OCT images in vivo. And does anybody know how I get rid of this? More? Hide video panel? Ah, there we go. Thank you. Right. Okay. So the black and white images are actually the OCT images. And then because we were imaging on women who were scheduled for surgery anyway, we had access to the tissue after all. So we could take a histological section in the same place we imaged and compare the two. So normal is not very exciting in an ovary. You can kind of see the surface structure. You can see some invaginations. You can see some clefts. These things are actually important. This is a risk area, but this tissue is completely normal. It's boring. Benign cysts, in this case, we can see these holes here. They can either be filled with fluid like this one. They can be filled with a scattering material, which turns out to be blood. There's a cystadenoma that we're imaging through the wall. And in this case, we can see that the bottom part of the wall is all smooth, just like in the histology section. A cystadenoma is completely benign. So it turns out that there was no reason this woman had to have that removed because it turned out to be benign. It may have been causing some difficulty, but it wasn't cancer. On the other hand, this one is a malignant cystic tumor, and it turns out that the structure in the wall looks quite a bit different, and you get these weird streamers into the cyst fluid. So this was kind of exciting because this is something you couldn't see from the surface of the tissue. The surface of the tissue was just smooth, but we could see through that cyst wall and see which one was normal and abnormal. So again, that was exciting, even though it wasn't incredibly useful. So scratch laparoscopically. We're going to go on to other ways of accessing the ovaries. And so I was curious. I thought, well, you know, if you can go transvaginally for egg harvesting, can you go that way for diagnostic procedures? And it turns out that people already have. There's something called the Fertiloscope, which, no surprise, is used to diagnose reasons for infertility. So it's actually this complicated instrument here shown in a model of the reproductive tract where you have, you know, one part that goes into the uterus, you have another part that goes into the abdominal cavity, you fill it all up with water, you float the fimbriae of the fallopian tube, and you take a look around just with a white light scope. But I was excited to see that there was something that was FDA approved already that already went, you know, it makes it a lot easier. Right, it means the difference between having to do pre-market approval and being able to do a 401. So we knew we could do that. A couple of advantages: the endoscope can be large because, and you don't have to suture back up the hole that you make in the vaginal wall. It will just heal. It can be rigid, or you could have a flexible tip maybe to look around. You can visualize the ovaries and the distal tubes only. So if you have a 4mm scope, you're not going to be able to get into the small parts of the fallopian tube. So here's a design, and Nikki worked a little bit on this. So this was a design for what we call a salpingoscope. Salping, it has to do with the fallopian tubes. It was a forward imaging system, 3.8mm in diameter, so fairly large. And it had a whole bunch of things. Here is a scanning fiber. So the fiber scans back and forth. A lens system that then projects that illumination on the tissue. And you can collect back the light that's remitted back from the tissue. If it's reflected light in the near infrared, you can use it for OCT. If it's fluorescent light from visible wavelength excitation, you can do fluorescent. So it turns out you can also do multiphoton microscopy with this, which I'm not going to get into. It contained other channels for irrigation because you have to put saline in while you're doing this, and biopsy, just in case you see something irregular, you could put a small biopsy biopsy forceps through and take a biopsy. So here's the assembly. So Nikki, was this fun to assemble?
I was going to say no, but I kind of missed it now.
It was a challenge, right? It was a challenge. So we built it and we did proof of concept of this. Unfortunately, this was a little bit of a COVID casualty. We actually wanted to test this in a sheep model because it turns out that the veterinarians know how to do this procedure. They're like, we do IVF all the time. Animal husbandry is just an amazing field, which, maybe someday go find out about it because we have an amazing ag program here. So they do this type of thing all the time. And they were all like, oh yeah, we can do this. We can take your endoscope and our sheep and check this out. And the nice thing is it doesn't even really harm the sheep. So the animals were going to get to live a short and healthy life, probably until they got turned into somebody's dinner. But any rate, we did this. We were able to get some images with it. It really was a heroic effort, though. So this is not something that we decided was really appropriate to take to clinical practice, but it was a lot of fun, and it was a great optics experiment. All right, we decided we wanted to focus on the falloposcopic access, and so here we had a couple of challenges. The first is that this is the uterus, the fallopian tubes, and the ovary. It's a tortuous path, right? It's not a straight shot. You have to use a flexible endoscope. There's a tiny opening here. I think I have this. Yeah, millimeter. It's a millimeter in diameter, but it's not even a nice tube, right? It's floppy. It's filled with these things that enter into the lumen there that you got to flush out of the way, and it's also very large by the time you get to the end of it. So you have to be able to look around. So we knew we were going to have forward imaging for just navigation, just to see where you were going. And so we decided, okay, forward viewing for navigation. It's still pretty big. OCT has a field of view of millimeters. So even if you have a fallopian tube that's 14 centimeters long, that's a lot of doing OCT. So we wanted to have kind of a surveillance technique. And it turns out you can use fluorescence imaging for that because the parts that are abnormal will fluoresce a little differently. Fluorescence imaging is typically very sensitive, meaning it's good at picking out things that are wrong, but it's not very specific, which means it picks up a lot of things that aren't cancer. They're just different. So we knew that we could do the surveillance with this multispectral fluorescence imaging, and then we could zoom in on the spot that looked abnormal and do OCT and see if it really was. So there's the endoscope. We'd put it into the uterus and we'd image. So here's our design. And so the first thing you do is SolidWorks, because SolidWorks is easy, right? You make sure everything fits, and it looks like that's no problem, right? That's going to be so easy to put together and so easy to make. This is 0.8 millimeters in diameter. It's got a stainless steel ferrule here at the end, and that mates to a multi-lumen extrusion. This is a cross section of this multi-lumen extrusion. I want you to keep in mind that this is 710 microns in diameter, this piece of plastic. And these holes in here are 125 microns. So they're about a human hair, my human hair, not thick human hair. And so it was pretty fabulous. I was talking to the company that made this for us, and they were talking about how they still go around showing people what they can do. This is an example of kind of pushing their boundaries, but yeah, it came out really nice. All right, so we've got heat treated tubing over it. We've got a 3,000 element fiber bundle. Unfortunately, that means that our image is only going to have 3,000 pixels, right? But that was the biggest fiber bundle we could pick in there. There's no sensors yet that are small enough to put in there. So we can't do chip on tip, they call it, what they do. Although we might change that in the future because the sensors are getting smaller and smaller. But for now, we have a 3,000 element fiber bundle, a grin lens on the end. The OCT probe is down here in red. It's side viewing. So, you look where you're going. You put your endoscope down on what you want to image and you pull it back to do the OCT image. It's got some round stainless steel pull wires and illumination fiber, a lot of stuff to cram into a little device. But we've done that. And so even with 3,000 pixels, it's pretty amazing. You can still see things. This is just testing the performance with an Air Force target. Obviously, as you get closer, you have better resolution, but lower field of view. This was a selfie done by one of the students who first built this system. So, you know, I can tell who it is, even though it's not the best portrait. Access. So we had to figure out, you know, how we're going to take this little thing and turn it into something that the physician was comfortable with. So we decided to use an introducing catheter that's already on the market, and it can go through this introducing catheter, and the introducing catheter just goes through a conventional hysteroscope. So here's the whole thing kind of put together. This part is a hysteroscope that just goes into the uterus. The introducing catheter goes up to the ostium, or the entrance of the fallopian tube, and you probably can't even see it on here. You know, the part that goes into the fallopian tubes is at the very end, and it can push out and pull back. Here's just some more images of this. Here it is packaged to go through sterilization. So we worked with Banner, the hospital. We put it through their infection control and showed that we could use it over and over again. However, for the studies we're doing, it's just being used once. Here's some multispectral fluorescence imaging, false color. So this is actually pig tissue that we got. But what I like is that even though the pig tissue itself just looks kind of pink, if you look at the fluorescence colors, you see that follicles kind of glow greenish, fat glows yellowish, and collagen glows bluish. So this is where you can get the different information. This is all normal tissue, but different types of tissue fluoresce differently. So this is us. We just recently started our first trials in women. So there's been a bit of press about this lately. I don't know if anybody's seen any of that. But this is our 3,000 element fiber bundle actually going into the fallopian tubes. And if I can catch it, I'll point out where we did see an irregularity. These women were normal volunteers. But there's that it just passed. There we go. There was something we just passed, which was sticking out a little, you know, it wasn't cancer, but it was a strange abnormality. So anyway, we're able to do that. And one of the things we need to work on is, you know, trying to mosaic or de-pixelize the fiber bundle. There's algorithms for doing that. We just haven't done it yet. You can end up with pictures more like the one down here. But at any rate, yeah, we were able to take pictures. So what have we done? We've demonstrated optical imaging can be used to distinguish cancer from normal. You can build these little teeny tiny endoscopes. You can perform benchtop feasibility studies, which we did several years ago. And we're now to the point where we're demonstrating imaging, just really to prove that we can get the endoscope into the fallopian tubes and image. We next have to determine whether or not we're able to image these very early stage cancers of sticks. The experiment we're doing right now isn't designed to do that, but we just got a grant to be able to do that next. We're constantly working on what I call light tech, because you eventually need to make these things disposable. And so you have to figure out how to make them inexpensive, both in the parts cost and in the assembly. Right now, they're way too expensive. Not even so much in the parts cost, but they take, you know, a couple of weeks for a graduate student to make one. And we need to make probably 100 for the next study. And then exploring the market and acceptability, because it's, you know, it takes a long time to get a medical device to market. And that's one of the things you need to make sure is that the physicians are very comfortable with, and then you prove that it's worth the cost to be able to use. So with that, I'll finish. Thank you very much. Uh-huh.
Do you want me to ask you?
Or I can maybe just stop the sharing then. So now I can see it. Hello. All right. So the question, how does the wavelength of light used for these imaging methods affect the result? When you mention light, are you only speaking about visible? Is there only a small bandwidth which you could use the cancerous cells, or you could use UV or IR light for a different result? Great question. So for fluorescence, typically there's different wavelength ranges that your endogenous molecules fluoresce. And then if you use an exogenous dye, then there's different wavelengths that's designed for that. And they can go anywhere from the UV to the near infrared. The UV light, you have to worry about it possibly being mutagenic. And so putting UV light on reproductive organs is probably never going to be acceptable. It's not explicitly banned by the FDA, but it would be really hard to get that to work. So we just We actually started off with UV and then just decided, no, we didn't want to go there. So for fluorescence, we're focusing on the visible, and for endogenous fluorescence, blue is the, usually excites the most, but there are some molecules that are excited better in the green. And then you can go all the way up to the near infrared for other things. Some natural things, porphyrins will fluoresce in the red, but mostly it's the dyes that fluoresce in the red. And then it turns out that optical coherence tomography, you want the greatest depth that you can get. And so you want a wavelength that penetrates deep into tissue. So that's the near infrared, 1300 nanometers is about the optimum for that.
Question.
Yeah.
Do you have to worry about temporal artifacts whenever you're trying to image through the fallopian tube?
So we call that motion artifact, just from the patient is moving. We have the physician actually pushing the scope through, and he's pushing it. So yes. So that's why for navigation, we typically will use reflected light. And so you can image it at video rate, so you don't get bad motion artifacts. When it goes to taking fluorescence light, you will have motion artifacts in there because you probably need integration times up to maybe half a second. But the good news is you don't really need great resolution for that. That's more of a detection technique. If you see something that's glowing differently, fluorescing differently than the surrounding, then you want to investigate it further. So for that, some motion artifact is acceptable. For OCT, we're hoping that we're in contact, and OCT is actually a very rapid imaging technique. So normally we haven't had huge problems with that either. But yes, we do worry about it quite a bit.
Is it painful for the patient?
That's a really good question. So this first group of patients that we're starting with are volunteers who are having a surgery anyway. And so they're under anesthesia, so we don't know. And actually they're getting their fallopian tubes removed. So it's really no risk to them to do this procedure. So there has been some thought about whether or not this is something you could do in an office procedure. I can tell you for sure we could do it like a colonoscopy, where it's an outpatient procedure. It's kind of pseudo office or maybe outpatient hospital. You're under sedation. You don't remember the procedure. It is painful, actually, but that's okay. That would be fine, and that would probably be acceptable because you wake up and you're a little groggy for a while, but you're fine. We'd love to move it into something where you didn't have to have sedation, maybe just local anesthesia like lidocaine. And the lidocaine would negate, because it can be painful having things go into, I don't know why you have nerves. Why do you have nerves? It's like anybody's had gas, right? Wonders why you have nerves in your bowel. Why do you have nerves in your fallopian tubes? But at any rate, yeah, that would help with that. And so the question is, will it be tolerable, and can it be fast enough and everything to do in an office procedure? That's our hope, but I don't know for sure yet. Yeah.
What are some of the challenges you think you'll face, and sort of the last thing you talked about, like bringing this to market, marketability?
Yeah, so it's always a matter of proving that by introducing a new technology into the healthcare market, you're not just increasing the cost of healthcare. Goodness knows the United States doesn't need that. We spend 10 times as much as other countries that have better outcomes than we do. You have to prove that you're actually saving life and quality of life. So it's really important that you figure out who your market is, and you figure out and you prove that equation. And it turns out that there is an equation. There's an equation for what a life year is worth at different ages. So, I mean, actuaries, right? They already know this for life insurance. So you can, if you save a woman from dying from ovarian cancer when she's 40, then, you can count that benefit versus the number that you'd have to screen to save that one life and how much that costs. So you can do that equation. So we need to make sure that that works well. The other thing is, even if you do get that equation down pat, you have to make sure that people will actually use it. And that's why I keep, saying you've got to get physician input, and you've got to make sure they're comfortable with it. Right now, our device takes 4 hands. We can't, that's not going to work, right? It's got to be something you can do with 2 hands. And so that's one of the things we'll work on fixing. So, yeah.
Is this something that you think would also be able to like be applied to other like reproductive issues like diagnosing endometriosis and adenomyosis, or
Yes.
this is strictly for cancer?
So we specifically designed, because we had to make a lot of trade-offs to make it so small. So if we were going to look for endometriosis and only needed to enter the uterine cavity, we could do something a lot bigger that would be better quality. But in terms of, looking for other dysfunctions of the fallopian tube, like salpingitis, which is actually a pretty common problem, looking for blockages in the tube that could lead to infertility. Actually, yes, you could use this exactly the way it is.
Another question.
Yeah.
No one else does. Okay. Can you talk a little bit about the patent process that you went through to get this design patent?
Yes. So quite some time ago, when we came up with the device, we contacted Tech Launch Arizona, which is our technology transfer organization here on campus. Is everybody familiar with Tech Launch Arizona? Kind of, yeah. They're really nice, actually, and they are interested in talking to students. You don't have to be a faculty member. If you have your own invention, actually, if you have your own idea as a student that was as a result of a class or something like that, you came up with it in senior design, or, well, that's a bad example, because usually you sign your intellectual property rights over in senior design. But if you came up with an idea on your own, it actually belongs to you, not the university. If you came up with it as an employee, if you're a graduate research assistant, or you're a trainee, or you're a paid undergraduate assistant or something like that, then it belongs to the university. So, but the good news is that inventors get, so you can talk to Tech Launch and they'll talk to you either way. Okay, now, if it's going to belong to you, probably they want you to suggest who might pay the cost of patenting for it, right? Because, honestly, the university isn't going to want to put, tens of thousands at least of dollars into a patent application just to hand it over to somebody. But if it belongs to the university, they may do that, thinking they'll be able to relicense and recoup later. Regardless, they can put in a provisional patent, very short order. That allows you to start talking about your invention. You can talk about it at conferences. You can talk about it with companies. You can do things you want, get people interested, and you have a year before you have to convert it to the expensive version. So it kind of gives you a year to get interest. We did the provisional patent. We didn't have anybody who was willing to license it yet. So the university paid for the full patent for this. That was 5 years ago, and it just got released a little while ago. Unfortunately, patenting is a very long process, or at least it can be. We had to go through 2 iterations of getting comments back from the examiner. It's now patented, and we're still looking for a company to license it. Companies want us to prove that it works, that we can detect sticks. So I'm like, we have one more grant from the NIH, and then I hope that somebody will license it after that, because we can't put this into production. Once they license it, then the company who licensed it will pay fees back to the patent owners. And if that's the university, but you're the inventor, then a very large fraction of those go back to you. Some go back to the inventors individually, some go back to the departments of the inventors, some goes back to the university, basically, to, so they can recoup their patenting costs. So that's kind of how it works. So they will help you. They've got some great people there. They can do a market analysis. They can look up competing intellectual property. They can make sure this hasn't already been published in the literature. They can suggest people to talk to, but you really do need to drive it as well. You've got to be the one to go out there and talk to the companies, because they want to talk to the inventor. They don't want to talk to the patent or the technology licensor. Yeah. Yes.
What's your favorite part of your job?
People. Yeah, I mean, I did a podcast for Bio5 that's now out there, and I was talking about this, and it's funny, sometimes when you're talking on those things, your mind is just racing and you forget what you said and you go back and you listen to it, and it's kind of funny. But I was saying that, really the reason I was here at the University of Arizona was because of the students. That's my favorite part of the job. I would never just want to go to a research institute or where I could do the same work and maybe even get more resources for it, but I wouldn't have the students to work with. So that's my favorite part. All right, anything else? Thank you so much. I really appreciate you taking the time to listen to me.